Hi everyone, our subject today is congenital hearing loss. Basics. Incidence 1 to 2 per thousand infant are diagnosed with hearing loss. Congenital hearing loss, 50% due to environmental or acquired causes, viruses, cytomegalovirus, rubella, measles, mumps, kernicterus up to 20% will develop high-frequency hearing loss, syphilis, 50% due to genetic factors. 70% of genetic hearing loss is non-syndromic. 30% of genetic hearing loss is associated with the syndrome. Inheritance pattern of common genetic hearing loss disorder. 75 to 80% are autosomal recessive. Connexin 26, most common non-syndromic genetic cause of congenital hearing loss. Usher syndrome, most common autosomal recessive syndromic hearing loss, sensorineural hearing loss. Retinitis pigmentosa, Jervell and Lange-Nielsen syndrome, profound sensorineural hearing loss, prolonged QT, often treated with beta blocker. 20% autosomal dominant. Waardenburg syndrome, most common cause of autosomal dominant congenital deafness, variable degree of sensorineural hearing loss. Also, white forelock, heterochromia iris, premature graying, vitiligo. Bronchio-otorhinal syndrome, variable forms of hearing loss, also bronchial tags, fistulae, and renal abnormalities. Stickler syndrome, sensorineural hearing loss or mixed hearing loss, also with the craniofacial abnormality. Treacher-Collins syndrome, conductive hearing loss, ossicular chain anomaly, also with the craniofacial abnormalities. 1% to 3% are X-linked, like Alport syndrome, defect in the type 4 collagen found in the basement membrane, progressive sensorineural hearing loss, also with renal failure and hematuria. Top tips. As parent may not recognize mild or high-frequency hearing impairment, and as hearing impairment has a major impact on the child language and communication, screening during the neonatal period is strongly advocated and usually performed by the third day of life. Any child with congenital deafness should be tested for cytomegalovirus infection, as this infection is the leading non-genetic causes of hearing loss. Red flag. Congenital deafness due to congenital infection or genetically determined impairment may escape neonatal screening test and deteriorate during the first 2 years of life. Some children with congenital cytomegalovirus suddenly lose residual hearing at the age of 4 to 5 years. Diagnosis and evaluation. All neonates should be screened with the first year of life. Identification of permanent hearing loss should occur by 3 months of age. Screening with the auditory brainstem response or autoacoustic imaging test. Neonate with the risk factor should be re-evaluated with the auditory brainstem response at least once before 30 months of age. Bilateral failed hearing screen require urgent evaluation and treatment. Less likely to be false positive test. Refer to an otolaryngologist and offer genetic consultation. Application of hearing aids by 2 months of age. Unilateral hearing loss, reduced sound localization and hearing discrimination in noise, does not affect speech and language development but puts patient at risk for poor school performance. Neonatal hearing loss risk factors. prolonged neonatal intensive care unit admission, in utero infection, toxoplasma, syphilis, varicella, parvovirus, rubella, cytomegalovirus, herpes, strong family history of hearing loss in childhood, craniofacial abnormality, neurodegenerative disorder, trauma, extracorporeal membrane oxygenation, chemotherapy, cranial radiation, persistent pulmonary hypertension, birth weight less than 1,500 gram, hyperbilirubinemia requiring exchange transfusion, low Apgar score, 4 at 5 minutes and 6 at 10 minutes, ototoxic medication like gentamicin, and mechanical ventilation, especially for more than 5 days, or extracorporeal membrane oxygenation, as we mentioned. Prenatal exposure to retinoids, cisplatin, and certain toxins like alcohol, mercury, quinine have also been associated with hearing loss. Screening test with the auditory brainstem response using EEG to measure electrical activity from the auditory nerve to the midbrain when sound stimulus is presented. It is unaffected by ambient noise. Objective test that does not depend on behavioral response of the subject. Therefore, it is best for patients who cannot participate in pure tone audiometry test, like newborn, young age, developmental delay, or even for evaluation of malingering. For accurate thresholds, child must either be asleep or sedated, unreliable if child is awake, and sedated sleep. Auditory brainstem response test is possible in children less than 6 months old. Auditory threshold can be estimated based on auditory brainstem response result. Screening with the autoacoustic imaging test measures sound generated by mechanical activity of outer hair cell in the cochlea when a sound stimulus is presented. Absent in ears with more than 30 decibel hearing loss. Presence of autoacoustic imaging test suggested normal cochlear sensitivity. Does not predict precipitation of sound because autoacoustic imaging does not measure transmission of a neural signal from cochlea to the brain. Relatively simple to administer, does not require electrode placement, can be used for several applications, used for newborn hearing screen, evaluation of malingering, and monitor of cochleotoxic medications. Diagnostic test, pure tone audiometry, sound stimulus delivered as a sound field if a child is too young to participate, like those below 2 years old. Hearing threshold to this type of stimulus reflect performance of the better hearing ear and cannot rule out unilateral hearing loss. Older patients undergo testing of air conduction threshold via headphone and bone conduction threshold via bone oscillator on the scalp. Method depend on the age and cooperation of the child. Behavioral observation audiometry from birth to 5 months of age. Observe changes in behavioral that reflect perception of sound stimulus presented as a sound field. Ear-specific information is unavailable. Result depend on skill of tester. Visual reinforcement audiometry from 6 months to 2 years. If child looks up or to the side of sound stimulus presented as a sound field, he or she is rewarded with a lighted toy or video clip. Ear-specific information is unavailable. Results depend on skill of the tester. Conditioned played audiometry from 2 years to 5 years. Child shown how to listen and perform a repetitive play task whenever a sound stimulus is perceived. Ear-specific information available because a headphone and bone oscillator can be used at this age. Thresholds obtained via this method are as reliable as those from conventional audiometry. Conventional audiometry, more than 5-year-old, gold standard test. Child raises hand or push button whenever he or she hear the sound stimulus. Interpretation of audiometric test. Degree of hearing loss: 0 to 20 decibel normal, 21 to 40 decibel mild, 41 to 55 decibel moderate, 56 to 70 decibel moderately severe, more than 70 decibel severe to profound. Sensorineural hearing loss. Both bone conduction and air conduction threshold are increased. No air conduction bone conduction gap is present. Conductive hearing loss. Normal bone conduction threshold, but air conduction threshold is elevated. Air bone gap. Difference between air and bone threshold measurements. Mixed hearing loss. Bone conduction and air conduction threshold are both elevated but not equal, suggesting presence of both sensorineural and conductive hearing loss. Tympanometry. A probe is inserted into the ear canal and an airtight seal is created. A sound is introduced into the canal where a pump generates negative and positive pressure. A microphone detects the returned sound energy. Tympanometry measurement tympanic membrane mobility and middle ear function. Type A, normal tympanic membrane mobility and middle ear function. Type B, flat line reflecting little to no mobility of the tympanic membrane, like in middle ear fluid, cholesteatoma, middle ear tumor, scarring in middle ear, and tympanic membrane perforation. Type C, negative middle ear pressure, like in Eustachian tube dysfunction. Sensorineural hearing loss. Ototoxic drug exposure like aminoglycoside, gentamicin, tobramycin. Chemotherapeutic like cisplatin, carboplatin. Loop diuretic, furosemide, ethacrynic acid. Non-steroidal anti-inflammatory drug like salicylate. Infectious bacterial meningitis, cytomegalovirus, measles, mumps, rubella, syphilis, toxoplasma. Genetics like Albert syndrome, connexin 26 mutation, Jervell and Lange-Nielsen syndrome, neurofibromatosis, Bendard syndrome, Stickler syndrome, Usher syndrome, Waardenburg syndrome, developmental problem, cochlear malformation, enlarged vestibular aqueduct, tumor, cerebellopontine angle mass. Causes of conductive hearing loss: cholesteatoma, craniofacial abnormality, cleft palate, golden heart syndrome, Treacher-Collins syndrome, Eustachian tube dysfunction, external auditory canal obstruction, atresia, cerumen impaction, foreign body, tumor, middle ear effusion, ossicular chain abnormality, otosclerosis, tympanosclerosis, congenital malformation, disruption of the ossicles, erosion from chronic infection, trauma, and tympanic membrane perforation. Thank you for your listening.